Recording in progress.
Good morning, good afternoon, good evening, good night, whatever time it may be that you're logging on. Set my timer. So we are week 4, lecture 1. And as you know, on February 2nd at 1 p.m., you have your first exam. The content of this lecture will be part of that exam. So I don't know how far we will get into this. We're going to leave cholinergics and go into anticholinergics. I hope I can move through it faster. Let me turn my timer on. The reason I say that is because, this is high yield information. And if you understand the parasympathetic, sympathetic nervous system and how they work, it makes drug application easy. And that's why we focus on this. But let's go ahead and get started. Let me pull up. I have the lecture right here that where we left off. Just need to share that screen. Excuse me. I'm drinking a Diet Coke. There it is. Okay, very good.
You have started screen share.
I don't know why Zoom is doing. I don't know if y'all can hear this voiceover stuff. It's weird. Something new. It's something that I clicked. Okay, we are leaving cholinergics and we're going into what we call anticholinergics. So also parasympatholytics or antimuscarinics. There's a lot that goes into it. But if you look over here, the drugs that when we talked about the cholinergic medications, many of those drugs had a niche. There was something that like 1 in a million use them. You're going to see on this multiple drugs. Aclidinium, that is what we call a long-acting muscarinic antagonist or an anticholinergic for COPD. Atropine has various utilizations within emergency context. Sinus bradycardia that's symptomatic, etc. Benztropine. We can go on and on and on down the list, but these are many drugs that you will use clinically in your practice over many, many years. So we're going to talk about these, and that's where we're going to do it. So when you think of anticholinergics or antimuscarinics or parasympatholytics, you think just the opposite of what we just talked about those muscarinic cholinergic agonists. Okay, so these are going to bind to muscarinic receptors or nicotinic, and they're going to prevent the effects of acetylcholine. They're not giving a pharmacological effect in and of themselves. They're just blocking the actions of acetylcholine and any other cholinergic agonist that we may have out there. But that's pretty much, again, the manipulation is of acetylcholine. But these are very useful agents that we use for multiple indications, from COPD to asthma to bladder, not obstructions, but urinary incontinence, I should say. This goes on and on. Neuromuscular blockade and surgeries, we'll talk about that. But various names, you'll hear them: anticholinergics, antimuscarinics, parasympatholytics. Those are some of the synonyms that you'll have for that. Ganglionic blockers, there, nicotine, right? And then we'll talk about that. And then our neuromuscular blockers as well. Again, whatever we get through in this lecture will be part of your exam 1, and we will move remaining content to exam 2. Okay, so what's going on with these antimuscarinics or anticholinergics or parasympatholytics? These block muscarinic receptors. Go back to those initial schematics or diagrams we had. It's the same process now. We're just blocking the effects of acetylcholine. So your antimuscarinics, they're not going to block nicotinic receptors, so we're really not getting a muscle effect, so to speak. But the problem when we talk about anticholinergics, antimuscarinics, when we use those terms, they're synonymous for our discussion. A lot of medications actually have antimuscarinic side effects, and that's one, diphenhydramine is one that comes to mind. We'll take that for its antihistaminic effects, but it also has pretty profound anticholinergic effects in sodium channel blockade. So it can really wreak havoc on some, especially as you get older and the elderly. So something to keep in mind. Tricyclic antidepressants fall into that. When I think you think of amitriptyline, those type drugs, but even some of your skeletal muscle relaxants such as cyclobenzaprine, and then the antihistamines, of course, Benadryl, diphenhydramine, dimenhydrinate, they come to mind. Doxylamine comes to mind. Hydroxyzine comes to mind. So here we are, our nice little schematic of what's going on. Again, when we talk about the parasympathetic nervous system, acetylcholine is our workhorse between the pre and postsynaptic neurons and at the effector organ. Remember, when we talk about sympathetic, when you get to the post ganglionic neurons, postsynaptic neurons, norepinephrine is the workhorse at the end organ or the effector organ, if you will. So here we are, we're on the sympathetic. So now we're blocking the effects of acetylcholine now, right? The site of action of antimuscarinic drugs, boom, right there. That's where we're working now. So atropine, gosh, this is probably, if we had to have a prototypical, this is it. We don't use it widely. It's but when you think of atropine, there's a lot of derivatives that are very similar to it, right? You can see some actions up here. There's your muscarinic receptor, there's your atropine, there's your scopolamine, that's another one similar to atropine. We're in essence blocking the effects at that receptor site of acetylcholine so it can't bind. So atropine, this is going to be, if you had to say, tell me an anticholinergic drug, I hope you would say atropine, but it's a tertiary amine, belladonna alkaloid. So if you're into pharmacognosy, again, that tells you a lot that's going on. But this blocks, atropine is a workaholic. It will block all types of muscarinic receptors. So you're saying M3, M1, M2, that's exactly what I'm saying. It has actions all over the place, but it's a tertiary amine, peripheral and central. Remember, I told you another one similar to atropine that we use to counteract the side. Remember, we give neostigmine to reverse those non-depolarizing neuromuscular blockers. Brand name is Rubenol, but it doesn't cross the CNS. Atropine does. Atropine does. So, but it binds competitively to prevent acetylcholine from binding to those muscarinic receptors. Now, again, the inhibitory effects we're seeing it in M1, M2, M3, so we see it everywhere. It's not, we don't use it therapeutically in all these places, but actions of the eye, what are you thinking? I'm thinking mydriasis, right? Remember bad sludge? All the side effects of the cholinergics, just think bad sludge, but just the opposite for the anticholinergics. But you get mydriasis, which means in essence, there's an abolition of a light reflex. You get cycloplegia. That's going to be paralysis of accommodation. I think that's probably the best way to put it. One thing, if you were talking about contraindications, we would never use an anticholinergic in someone who had narrow angle glaucoma because that can certainly increase intraocular pressure. But the gastrointestinal, visceral smooth muscles are relaxed. It reduces acid secretions in the cardiovascular system. This is a big one. Now, remember, we can that blockade of M2 receptors on that sinoatrial node, we will give it to patients who are bradycardic. And that's one of the biggest places we will use atropine is in the heart. Now, it's no longer part of the ACLS protocol in terms of someone who's in asystole or someone who's in pulseless ventricular attack or ventricular fibrillation, but we do use it in the protocols for certain bradyarrhythmias. So remember, we always give 1 milligram. We used to give a 0.5 milligram dose for that, but you'd have inhibition on those M1 receptors and on prejunctional neurons. What did that mean for the patient? It can actually cause some initial bradycardia. So now to overcome that, it's pretty much standard. We got rid of the 0.5 milligram dose. It's just the 1 milligram dose. And it is a blockade of those M2 receptors on your sinoatrial node. So yeah, it's going to increase your heart rate, right? So that's one place. In an urgent emergent situation, we use it. We'll use it if someone's having multiple secretions. A lot of times end of life, we can do under the tongue, sublingual, but that's pretty much where we use it. We can use it in ophthalmic procedures, so the list goes on and on, but that kind of gives you an idea of atropine and what they do. And we went through the actions here. Probably should have went to the next slide. I meant to forward through, but you can see on the eye, we're blocking that muscarinic activity. We're getting mydriasis, dilation of the pupil. We're getting an unresponsiveness, that abolition of response to light that I just mentioned, that cycloplegia, which is going to be an inability to focus to near vision. And then a big one, that intraocular pressure can rise dangerously. So you'd want to use in caution in someone who had something such as glaucoma. Now, one you will use is an active isomer, which is L-hyoscine. And we use this in the ED regularly, and you can take it's an injectable IM, and then we have oral tablets we can give that we will use as an antispasmodic. Now, remember, in the gastrointestinal tract, you're going to get that visceral smooth muscles are relaxed, so you're not going to have the cramping, if you will, the cramping. And it also reduces acid secretion as well. Again, remember, the big one is that pepsin that can cause just all kinds of havoc, especially when people have GERD. The erosion of the esophagus, esophagitis, and the sequela that can come with that. So I think it's very important to appreciate that. We talked about the actions on the cardiovascular. Again, I should have gone through the slides. I get to going. But again, the low doses, we don't do the low dose anymore, okay? We don't do that anymore. You get a slight decrease in heart rate. Low dose used to be we'd give 0.5 milligrams if it was just for sinus bradycardia. Now, back when it was under the context of ACLS protocols, when someone had a systole or pulseless electrical activity, we would give a 1 milligram dose of atropine. That was in the context every 3 minutes, up to 3 milligrams total. So we'd give 3 milligrams total if you went through 3 cycles of CPR without return of spontaneous circulation. The bradyarrhythmia dose was a 0.5. Again, as I mentioned, we went just straight to the 1 milligram dose, and you're going to avoid that blockade of those M1 receptors on those inhibitory prejunctional or presynaptic, if you will, neurons. So when you have an effect on prejunctional or presynaptic receptors, neurons, a lot of times you can get a release, and again, you're going to vagal down or bradycardic. So that's why we just go with the 1 milligram dose. That's going to ensure you get that M2 receptor blockade on the sinoatrial node, and you're going to have an increase in heart rate. The secretions we mentioned that you're blocking muscarinic receptors, specifically in salivary glands, and this would be used, any anti-muscarinic. Atropine is just what we're talking about, but it can be used for dryness of the mouth or xerostomia. And so you're over-secreted, so we're gonna dry it out. And then, of course, sweat and lacrimal glands, we have a decreased excretion. So this can be a problem, again, in the elderly, not necessarily middle age. I think there's compensatory, but the very old, and I've seen this happen, especially this past summer. We went through the summer of 2023, which was so hot. We had a lot of very old patients coming through that had heat strokes, and they had been working outside. But when you look at their medication profiles, it'll be medications that had, they were either anticholinergics or they had anticholinergic side effects. And the problem we have with that is you have elevated body temperatures because you're not sweating, and that is your cooling system, right? So you can see the problem in and of that. So that's something to keep in mind. Again, I would say any drug, unless you have a reason to give it, if a drug is an anticholinergic or has an anticholinergic side effect with it, I think as you get older, or they're very, very young, but usually typically the elderly, I think it behooves you to appreciate the risk benefit of that drug. And that's with any medication you do. But as specifically as we talk about anti-muscarinic agents, I think we need to appreciate that. And we did see that this past summer. But when we talk about reductions, though, you all know it's going to be a reduction in your sweat. You're going to get a reduction in your salivary secretions. You're going to get reductions in tracheobronchial secretions. You're going to get reductions in lacrimal, your tears secretions. So again, remember, when we give neostigmine, we give the glycopyrrolate, another anti-muscarinic, anticholinergic, to reduce those tracheobronchial constrictions and to reduce peristalsis and the potential for post-op nausea and vomiting as well. That's in the perioperative setting. So therapeutic uses, specifically for atropine, from an ophthalmic perspective, we will give it topically for its mydriatic actions and its cycloplegic effects, but that permits the measurement of refractive errors without interference by the accommodative capacity of the eye. It's going to be given directly into the eye. But we don't use atropine. We use short-acting antimuscarinics such as cyclopentolate or tropicamide, and that has pretty much replaced atropine due to atropine has a very long duration of action, so you don't want to walk around with dilated eyes. But then the antispasmodic, and we talked about the cardiovascular effects of it. We talked about the anti-secretory effects. Now remember, we use glycopyrrolate a lot of times for this because that doesn't cross the blood-brain barrier, and the reason that's important is because you don't get some of the CNS side effects. But again, atropine is going to always be someone who has a cholinergic crisis because they've come in contact with organophosphates. These are going to be nerve gases, insecticides, so on and so forth, and you get poisoning. We want to give atropine for sure on these patients. Okay, so we give massive doses of atropine over a long period of time to counteract it. But why? We get good CNS penetration, so we get good central effects or antagonism and peripheral effects. So we can block the central and peripheral effects of those acetylcholine or the toxic effects of anticholinesterases that we get. So again, those block acetylcholinesterase so you don't metabolize acetylcholine, and the end game is cholinergic crisis, right? So where are we at? So atropine adverse effects, that's easy. That's let me clear out my phone, guys. I apologize. I'm getting I took the week off to record lectures, and I'm gosh, I'm popular. That's okay. Let me clear these. So the actions or the side effects, again, what you need to appreciate is that bad sludge. It's going to be just the opposite. So instead of secretions, diarrhea, increased urination, lacrimation, salivation, now you're going to have dry mouth, dry eyes, potential for constipation instead of diarrhea, potential for urinary retention instead of the urge to go, and blurred vision. And you know the why behind that. We talked about the CNS side effects of that: restlessness, confusion, hallucinations, delirium, which can progress to circulatory collapse, and death. And that's going to be those situations when you have too much. So again, the elderly tend to be more affected by this. So it's something to keep in mind when you're prescribing these medications. We talked about the temperature regulation, so on and so forth. So yeah, atropine. Scopolamine, that is but one thing I want, when you have someone who comes in, so when you take drugs with anticholinergics, sometimes you get that potential to sleep or you get dryness. But a lot of times when you're overdosed on it, many times that's going to be excitation. So that's the restlessness. That would be something you would need to key in on and watch elderly and watch young people. We're seeing some people try to OD on diphenhydramine, which the concern there is more of the sodium channel blockade. But keep that in mind. Scopolamine, again, it is an antimuscarinic, and it's a tertiary amine that works peripherally and centrally. Now, with scopolamine, this is something that we use as a patch. And when you're using it for, say, post-op nausea and vomiting, you got to put the patch on before. It's not a rescue medication. If you're going on a cruise and you have issues with motion sickness, you've all seen the scopolamine transdermal patches. You need to make sure the patch is on at least 24 hours before you go on your cruise or before you go on your fishing trip. Okay, so keep that in mind, but it's going to have greater actions on the CNS, and you're going to get a longer duration of action compared to atropine. And remember, we usually use this as a patch. It is a scopolamine transdermal patch that typically we put behind the ear. But again, the excitement at high doses, you're going to get sedation if you use it at the normal dose, the patch. But again, one of the biggest signs of an overdose of anticholinergics is that excitation that you get and potential for euphoria. So that's, again, young people are taking massive doses of diphenhydramine, not realizing it has sodium channel blockade and it's messing with their action potential, but that's leading to death. Unfortunately, we haven't seen a lot of it where I'm at, but we have seen some. We have seen some. So it's not, I don't know if these are TikTok challenges or what. I say young people, I shouldn't really say that. It's typically young people who are doing stuff, but you see it with older individuals as well. But it seems to be more of the ones I've seen have been more in the teenage age range. So, but I haven't seen a lot of it, but it's more I've read about it. But there have been a couple come through the ED. And they were okay. It's just watch and wait. But again, the big thing for me with diphenhydramine, you try to take a ton of it for the anticholinergic effects and maybe get that euphoria, whatever that's going to be. You're just not going to pee or poop for a week. Who wants that? But that sodium channel blockade you can get with diphenhydramine. So something to keep in mind. But the therapeutic uses of scopolamine, this is something that you all will at some point prescribe or recommend. I believe it's over the counter, but it's going to be prevention of motion sickness. Now, if you're working in the hospital, it's going to be prevention of postoperative nausea and vomiting. So a lot of times anesthesiologists or CRNAs will place it on their patient the day before surgery. I think you really need to have it on before to get the benefit, but sometimes you'll see it the day of, but that's okay if they do. It's not a problem. But yeah, they work very well. A lot of times, though, if someone is going to go on a trip that's going to cause vestibular disruption for, say, motion sickness, like a fishing trip or a cruise, this is going to be your go-to. So they would change it every 3 days, but you're going to apply before you get sick. And again, it's just counteracting those motion sickness that you get when in the GI tract, the stimulation that may come with it. So prevention of post-op nausea and vomiting, we mentioned. Usually it's not everybody gets it, but it's those who have, there's a lot of different strategies, people who have had surgical procedures before, and they did have issues with post-op nausea and vomiting, because it can have morbidity with it and potentially mortality, I guess, in certain situations, but more morbid effects, I would say. But you definitely something you want to avoid in that population. And then the pharmacokinetics, similar to that of atropine, but exceptions, it's longer. So that's why we put such a heavy discussion on atropine, because you can get it. But there's another one, hyoscine, scopolamine. They work the same for the most part. But again, these are plant alkaloid and tertiary amines. And again, more CNS effects with these versus atropine. And then the therapeutic dose is, unlike atropine, causes sedation rather than excitation. But if you get to that excess point, you take too much, which you're not with scopolamine, you're going to do eat the patch. I shouldn't say that people would do that, but again, it's something that we can do. But most of the time, it's going to be that transdermal patch, and it's every 72 hours, and specifically, it's 1 milligram. I think I mentioned again, I say put it on 24 hours before. If you read the directions, it's going to say apply at least 1 hour before travel and change every 3 days. Again, I really think if you apply it the night before, whether it's surgery or your cruise or your fishing trip, I think that's when you're going to get your benefit. Now, after you've done your trip, do you need to leave that patch on? No, if you don't need it, take it off, because if you use it, you're going to see some of the sedation that goes with that. So keep that in mind and appreciate that. Some of the other anticholinergics and antimuscarinics, they work similar, but we're going to talk about these in future lectures, specifically when we talk about aclidinium, glycopyrrolate, ipratropium, tiotropium. There's others now, but these are used in chronic obstructive pulmonary disease. That's their main workhorse. In asthmatics, in the terms of an acute bronchoconstrictive episode, an asthma attack, your antimuscarinics are more useful when we use them in the context of COPD. when we think of asthma, we think of beta agonist and inhaled corticosteroids, but these are all quaternary derivatives of atropine, which means they're not absorbed. So they're just working topically in the lung. So that's really nice, and glycopyrrolate. So that's something to keep in mind. Remember, when it's a quaternary derivative of an agent, that means it's a charged molecule, so it's not inhaled. But we'll talk about these. Ipratropium, you're going to start, let's just go ahead and introduce it. You're going to see terms like SAMA, that short-acting muscarinic antagonist, or it could be a LAMA, that would be a long-acting muscarinic antagonist. Just when we get to SABAs, SABA, short-acting beta agonist, these are antagonists, remember? So anti-muscarinic agents. So SAMA is your short-acting anti-muscarinic agent. These are antagonists. And you'll see the term SABAs, those are short-acting beta agonists, and or LABAs. But we'll talk about these, but the end game is they cause bronchodilation. Remember, if a cholinergic causes bronchoconstriction, what if we give an anticholinergic? It's going to be bronchodilation. So, and the big use, though, is going to be in COPD, some in asthma, depending on the situation. We'll talk about those at a later date. So, summary of the common anti-muscarinics, which we will talk about again at a later date. The trihexylphenidil and the benztropine, you'll see this many times in treatment of Parkinson's disorder. You get movement. Remember, this is dopamine, so we're getting anti-dopaminergic activity as well in these, but it can be some of the movement disorders, and we'll talk about them. Management of antipsychosis or induced extrapyramidal side effects. Again, that's a movement disorder. That's something we see, like, for example, we will give with some of the ants when we give haloperidol at 2.5 to 5 milligrams IV to some of our patients in the ICU. A lot of times we'll give a dose of diphenhydramine with it. Why are we giving the diphenhydramine with it? To prevent those movement disorders or the movements that may come with it. So just something to keep in mind. But then overactive bladder, you can see the medications we will discuss. The list goes on and on and on. So we will talk about these at a later date. So keep that in mind. Now, real quick, ganglionic blockade. So nicotine, interesting drug. You wonder why people get addicted to it. Well, just take a look, go down the list of why. Need I say more? A lot of these are excitatory. Glutamate is your excitatory neurotransmitter. Gamma-aminobutyric acid is going to be the one that chills you out. They're equal but opposite, but you can see all the different neurotransmitters that are affected by nicotine, and to give a feeling of feeling good. And so, as you all know, this leads to pretty profound addiction, even more so than some of our narcotics. And it's hard for people to quit smoking, or now the big thing is vaping. So it does create a problem. But nicotine, the sites of action, they are ganglionic blockers. And you can see nicotinic receptors where we can potentially have an effect on the patient. So just something to keep in mind. But one thing about nicotine, you can actually overdose on it. It does have a lethal dose, 50%, and it causes a depolarization of the autonomic ganglia. So you get an increased release of neurotransmitters into that synaptic cleft. What does that do? You get the stimulation, and that can be the fasciculation you get, but then you can get paralysis of all ganglia. So nicotine in and of itself can actually be toxic and paralyze you if you took it in the doses that would cause you to release all of your neurotransmitters, have the initial stimulation, but then unfortunately go into paralysis. That's just a little pearl. I've never heard of anyone ODing on nicotine, but I worry sometimes with vaping, because who knows how much nicotine is being delivered to the individual who's partaking in such a thing, as they say, partaking in blowing a cloud. I don't get it, but it's there, and it's just another delivery form. So just something to keep in mind in individuals who use nicotine products, whether it's smokeless or smoking. So neuromuscular blockades, we'll have a further discussion on these, but we're going to go ahead and talk about them now. So really, when you talk about these, so we're blocking cholinergic transmission between the motor nerve endings and the nicotinic receptors on skeletal smooth muscle. So this is where we're working right here. So you have two flavors. You have depolarizing and non-depolarizing. It's very easy to remember which one is depolarizing because there's only one. It's succinylcholine. And as with nicotine, it causes you to deplete all your acetylcholine, and then that leads to paralysis once you've depleted it all. But that can lead to fasciculations, that can lead to hyperkalemia, that can lead to uric acid nephropathies. There's a lot of things that can come with that. It's also, when we talk about malignant hyperthermia, it has a higher association as well. So succinylcholine isn't necessarily a sexy drug per se, but it is used. We're going to talk about it. And then everything else is your non-depolarizing. And these are just true antagonists. And a big difference is that they don't fasciculate. They don't cause fasciculations because we're just blocking acetylcholine. And number two, the reversible. We're succinylcholine. The depolarizing is not. So that's where you got. So what do we use them for? We'll use them for rapid sequence intubation. This is one of several drugs. It's a process when you know you're going to intubate someone. But we do it to facilitate endotracheal intubation and, in essence, provide complete muscle relaxation during that RSI, so we can get the tube through the vocal cords down into the trachea. We'll use it in the ORs to facilitate endotracheal intubation before surgery. But it's typically, this is more of a one dose type phenomenon. If you need a longer duration of action, the reason succinylcholine, and all these are used it, but this is going to be, again, succinylcholine usually. But your products, your big ones are going to be rocuronium, vecuronium, and succinylcholine. So when I say these, it's not just sucks that we're using. We'll use the others, but we'll also use them in the neuromuscular blockers in the intensive care as an adjuvant therapy, again, to facilitate intubation if it's RSI. And we'll also give them as intermittent dosing or a continuous infusion, depending on the situation. We try as much as we can to avoid neuromuscular blockers in the ICU outside of RSI, rapid sequence intubation, or in the OR to facilitate or stop movement. We really don't like to use them. Now, sometimes we do have to have synchrony. People try to overbreathe the vents. Now, there's no sedative effects whatsoever. These drugs do not cause the CNS, so you want to make sure you always sedate the patient before you give them a neuromuscular blocker. And I'll just ask you the question, would you want to be paralyzed when you're wide awake? I think the answer is no. So you sedate these patients, but I don't know what the next slide comes to. So we'll talk about this as here so we can talk about them in more detail. But that's the uses. Rapid sequence intubation, that's more usually how we do that. We'll give a sedative, and a lot of times that'd be step one. We use a drug called etomidate. It's not a narcotic. It depends on the situation, but you'll also see midazolam. You'll see propofol. Once they're sedated, at that point, we'll give the neuromuscular blocker. That'll be the step. And we're doing bag mask ventilation, and you can say, well, what if you don't get them intubated? What if you don't get them tubed? Is that a problem? No, it's not. We can bag mask ventilate and have that oxygen flowing, and we're fine. So, but usually we'll give them the sedation. We'll make sure we get their O2 stats up to 100% if we can. Then we'll give the succinylcholine. That's going to be fast on, fast off, but it's not reversible, but it's fast on, fast off. If we can't establish an airway, again, we can bag mask ventilate. But when you talk about paralysis, remember, it's going to go from the outside in. So this is your legs coming up and your arms coming down, and then your lungs. So that the diaphragm is going to be the last thing to get paralyzed. Now, when you start coming out of paralysis, it goes from the inside out. Your diaphragm is going to be one of the first things that get going. Now, when we use them in the ICU, which we would never use succinylcholine for intermittent dosing or for continuous infusions, that's like a one and done. We will use rocuronium, vecuronium, cisatracurium we'll talk about. But we will test these patients. We'll do train of 4. And if you're ever working in an ICU on your rotations or the ED, ask to see it and actually use it and feel it. But you can use it on your thumb. You can use it on the eye, but usually we put it on the thumb on the ulnar nerve. And it'll send, for example, 4 shocks. And how many twitches do you get on your train of 4? 4 shocks, train of 4. how many twitches. So in the ICU, if you're covering as an intensivist in that situation, and some of you will, and you have to paralyze someone continuously, you may tell the nurse, okay, I want to train of 4, I want 2 twitches of 4. If it's someone who you want to increase O2 consumption in the CNS because they have a traumatic brain injury, in essence, you're putting them in a pharmacologic coma and you don't want any movement at all or anything. You might want to train a 4 of 0 to 4. That means they're 100% paralyzed, but they do come with a lot of side effects when you do it chronically, especially with some muscle wasting and some other types of myopathies if you use it with steroids. But again, remember, there's no sedative effects with these drugs whatsoever, so you do sedate the patient. But coming up here, after step 2, that's when you would intubate them. Now, RSI, I won't go into it, but in younger patients like babies, I work in the NICU, we will give atropine, and that's just because anatomically there's a lot of stimulation in the vagus nerve, and when you stimulate the vagus nerve, the baby can vagal down. So we'll give some atropine with it as an anticholinergic to kind of bump the heart rate. But we don't have to do that with adults. It's not really a problem. They recover quickly. But anyway, that's what RSI is. It's just rapid sequence intubation. Okay, we got to end. A lot of times the patient's alert and they agree to it. It's like, we got to protect your airway, and it's rapid sequence, but it's done in a controlled environment in a sequential fashion. Okay, so the non-depolarizing or competitive blockers. So it's real easy to remember when you think about it. What are the non-depolarizing agents? Well, it's all of them except succinylcholine. That's the only depolarizer. Now, I don't know if I went into big detail, so I'm going to talk about them here, but I just want to show you probably the next one with the shortest half-life is vecuronium, then rocuronium. I am a fan of rocuronium because it seems to have less cardiovascular side effects. Now, it does have a longer duration of action, but when you look at some Cochrane meta-analyses, and I've tried to have this, I don't like succinylcholine because I've seen some detrimental effects to it because of the fasciculation potential, and I've dealt with malignant hyperthermia before as well, related to halothane or anesthetic gases, and specifically succinylcholine in combination. But what I like about rocuronium from the Cochrane meta-analysis is when you looked at first-pass intubations, when you were using these in RSI, when you look at first-pass intubations, there was no different. An airway was established. Now, some will do that and give reversal to it because, remember, you can reverse these non-depolarizings. But that's one I like. The one you'll see in the ICU quite a bit is a drip. You'll see mainly vecuronium. Okay, Greg, why vecuronium instead of rocuronium? Well, it has a shorter half-life. It's a longer duration of action than succinylcholine. Succinylcholine is the shortest. It's the fastest onset and the shortest duration of action. That's why we like it in RSIs, or when we just need just quick paralysis. That's what makes it a good-looking drug. But VEC will be number 2, and then the list goes on. What about cisatracurium? When do we use this? I think this is very important, and I want you to appreciate this. Cisatracurium is something you're going to use in your patients who have acute kidney injury or chronic kidney disease, or their renal function just isn't up to par. That's a good one you can use, or liver dysfunction. The reason being, it goes through what we call Hoffman's elimination. It's actually metabolized within the plasma. So it's not dependent on end organ damage from metabolism. Now, it does have an active metabolite that doesn't cause paralysis, but it causes excitation. So there's the potential for the accumulation of the metabolite to cause maybe some seizure activity, and that will cross the CNS, but it doesn't prolong paralysis. But what you need to appreciate is, remember, you told the nurse, you guys wrote the order. Some of you are going to be doing this. You're going to be working in the ED, or you're going to be working in the ICU. So you're going to do train of 4, so you're not overdosing, all right? I want 4 twitches. Okay, I want 2 twitches in my train of 4. So anyway, your non-depolarizing agents, there they are down there. Those are the agents. I gave you some specifics of them, and there's nice handouts on it. But these are going to block acetylcholine at nicotinic receptors. They're just blocking it. So there is no stimulation of the receptor. It simply blocks it, preventing muscle contractions. And the paralysis are going to come from the outside to the inside. Okay, so I'll give you an example. Your standard dose of vecuronium is 10 milligrams. At end of life in patients who have been declared brain dead, and you all are going to deal with that, It's part of medicine. But when you withdraw care, they have a reflex, an uncontrolled reflex that families will see. They'll start twitching, and when families see that, they think, "Oh, they're moving. That we need to do something now. We were wrong. We're wrong." And it can cause a lot of detriment to the patient who we're trying to relieve of their suffering, to the family as well, who we're trying to help with the suffering that they're having to go through as well with their loved one. And they see that you can actually give, when you pull that, you can give a defasciculating dose of vecuronium, and it's just 1 milligram. Remember, the full dose is 10, rocuronium is 100. We can give 1 milligram, and that will just stop, that will cause paralysis on the outside, so they don't have fasciculations or twitching, but it's not going to stop them from breathing. That will, when you extubate the patient to comfort measures, that process will go in its natural form. Okay, so keep that in mind. But again, your choice of agent for the most part is going to be on your desired onset of action and your duration of muscle relaxation. But opinionated here, I'm a rock fan. So you'll hear succinylcholine referred to as sucks, vec, rock, cis, those terms. I'm one that I prefer people say the entire name of the drug. We get it, we know what it is, but anything that can mitigate the potential drug error or drug misadventure due to miscommunication is important to me. Okay, so succinylcholine, this is your one and only depolarizing agent. It's only one. So if that's your question, and I list all of these, which agent is a depolarizing neuromuscular blocker? Remember, there's only one, succinylcholine. And as we've already talked about, that's going to depolarize that junction, okay, by causing the release of the acetylcholine and in that synaptic cleft. So once you do that, in essence, you're going to get initial fasciculations, muscle movement, but in essence, what you've done is you have sustained the polarization of muscle cells, and that is paralysis. So again, muscle fasciculation occurs initially, then paralysis. So that's why we don't use them in patients who have had massive traumas or those who have malignant hyperthermia type risk. And you'll know a lot of times it's people who have acetylcholinesterase deficiencies or pseudocholinesterase deficiencies are at the increased risk. But again, the paralysis is going to be from the outside to the inside. The reason we like it is because it's fast on and fast off, but it's not reversible. Remember, the non-depolarizing agents, we can reverse them with neostigmine or a drug called Sigamadex, which works very quick. Neostigmine is going to be slow on. Sigamadex can reverse it. If you read the package insert, I've done some studies on, we have a paper we published actually on Sigamadex that I'll share if you would like it. Just ask and I'll send it to you. I have a copy. But say in the package insert, it reverses it in about 2 minutes. It's actually about 30 seconds. And I've seen a lot of tracheal vasospasms because that tube is still in there and the patient starts coughing. But it's just within 30 seconds that Sigamadex will start to work. Now, again, that's going to be reversal agents for your non-depolarizing. Depolarizing, succinylcholine, there is no reversal, but it's quick on, quick off. Now, these are the agents, the halothane and isoflurane. These give you an increased risk of malignant hyperthermia. And the reason we don't like to use it in trauma patients is because it can lead to muscle or cell lysis and myopathies because you already have an underlying concern of muscle bone injuries, and then you get those fasciculations, and that can exacerbate problems. But here you go, you can look at them. Here's all the agents. Atracurium is off the market, but this will give you an eye how we use these. You don't really see pancuronium much, but you can see there's your rocuronium, you can see your onset, and you can see your duration a little bit longer. So that's another reason why a lot of providers will not use it. But VEC is probably going to be, after sucks, VEC's going to probably be the next go-to, number 2 when we talk about it, and then 3, rocuronium. When it comes to RSI, it just depends. But when it comes to RSI, I'm a rocuronium fan. When it comes to the ICU, we're not going to use succinylcholine in the intensive care unit unless it's in the context of rapid sequence intubation. You're probably going to see vecuronium to maintain paralysis after you get whatever you need from succinylcholine. But that's a good table to know. Okay, so now we're going to get into adrenergics. So this is going to be the sympathetic autonomic nervous system. So you already know that the endogenous messenger, the endogenous hormone, the endogenous chemical in the SANS is norepinephrine. That's what does all the work. And you know, epinephrine is a hormone that will come specifically from the adrenal medulla released into the blood. But in all, we refer to these as catecholamines. Okay, these are sympathomimetics. So if it's a lytic, it's working against it. If it's a mimetic, so a parasympathomimetic, a parasympatholytic, a sympathomimetic, a sympatholytic, so for or against. But when we think of catecholamines, I want you to think of epinephrine. I want you to think of norepinephrine. I want you to think of isoproterenol. That's something we use every now and again. It's more specific to beta-1 receptors. And dopamine, but these are your big four. Your number one is going to be norepinephrine. So all of these have a very rapid onset and a rapid offset. So when we do give them, we give them as continuous infusions to maintain the effect. Now, as you know, if you've gone through your ACLS training, we do give epinephrine as an IV push for advanced cardiac life support. But your non-catecholamines, this is going to be phenylephrine. These are going to be work more indirectly in some cases, not in the case of phenylephrine. But phenylephrine is a pure alpha agonist, but ephedrine, amphetamines, and these tend to have longer durations of action. But as we say, the drugs that activate adrenergic receptors, those are sympathomimetics. Drugs that block activation are sympatholytics. So please appreciate this. Now, this is a table that I need you to know, okay? You need to know this, and you need to understand this. Now, alpha-1, right? That's what we give vasoconstriction. And we can block alpha-1. We have alpha-1 blockers like prazosin or trazocine. We don't use those because they have profound orthostasis-type concerns, and people can get syncope or presyncopal and fall. But when we give phenylephrine or we give norepinephrine or epinephrine, the drugs that bind to alpha-1 receptors, we can use it to increase blood pressure, right? So, or in the case of ophthalmic procedures, mydriasis. So, or increased closure of internal sphincter of the bladder. You can see what's going on. So we can give alpha agonist or alpha blockers. Alpha-2, these work centrally, and these work like inhibition. So clonidine is a drug we give for blood pressure to block the release, the inhibition of norepinephrine centrally. Another one we use for sedation is a drug called dexmedetomidine. In and of itself is an alpha-2 type drug. And then we talk about other adrenal receptors, beta-1. This is going to be specific for the heart. And what do you get? Tachycardia, increased lipolysis, myocardial contractility. You already know about the increased release of renin, right? What does renin do? Well, the end game, you know that's sodium and water retention or volume expansion. So it comes into that fight or flight. And then your beta-2 receptors, then again, we give beta blockers, we give beta agonists for asthma, right? Bronchodilation. We can give blockers for someone who's tachycardic, but this is a good table to know. I think it'll help you, but don't memorize it. Please try to understand the why behind it so you can make it applicable when you get further in your practice, not just your studies, but your practice. Now, you were studying to pass the test, but now that you're in PA, remember you're studying to apply what you learn to the patients you will care for. I get it. At the end of the day, you still got to pass the test, but I wish someone would have given me a more detailed scolding on don't memorize just for the test, Greg, when I was in pharmacy school. Had to relearn a lot of stuff. Oh, yeah, I remember that. So our receptor, so here's our alpha receptor. So alpha-1, this is going to be located on postsynaptic membranes of the effector organs. This is going to stimulate or it's going to constrict. And you'll have alpha-1A. Remember, we talked about specificity. This helps. So you said, okay, if we're using an alpha blocker, for someone's BPH, for example, they can't pee, and we're using an alpha blocker in the prostate. and we're using terazosin, but he said, okay, we try to avoid that because of the orthostasis, especially because your baroreceptors, as you get older, you don't think you're aging, but you are. The baroreceptors wear out, and things that used to work just fine for you, you stood up, now you stand up real quick and you fall flat on your face. It happens, and it's an aging process. Those receptors don't respond as they used to. So we can be more specific. We can have like Flomax, tamsulosin, which is more specific to an alpha receptor on the prostate gland to get the benefit of decreasing the size or the hyperplasia of the prostate so a man can pee, urinate, if you will. So keep that in mind. So selectivity or specificity is very important. But you can see alpha 1A, 1B, 1C, 1D. This just adds specificity to drug therapy. And then alpha 2, these are located on sympathetic presynaptic nerve endings and control the release of norepinephrine with the resulting decrease in norepinephrine release. So these are going to actually be centrally acting agonist. We don't, a lot of times the drugs we use, and that's going to be clonidine. So you think, wait a minute, that's going to lower blood pressure as an agonist? It should raise it. No, that's alpha 1 in the periphery. We're talking about centrally now. But you can see the specificity, the higher affinities, adrenal receptors. Isoproterenol is pretty much all beta. So you wouldn't want to use it for blood pressure, right? While norepinephrine, you're going to get some beta effects, but you're also going to get some alpha effects. And then with epinephrine, you're going to get more alpha. And then when you talk about the beta adrenal receptor, beta receptors, again, low affinity versus high affinity. So that can help you pick. Dopamine is not in there. I'll tell you right now, dopamine used to be the drug of choice as a pressor. When we say pressor, that's giving something to increase blood pressure. So when you hear that term pressor, that's what that means. So dopamine used to be our go-to, but I want to explain something. In order to cause constriction, you're going to have alpha innervation. Well, the standard dose of dopamine was 5 to 20 micrograms per kilogram per minute. Okay, 5 to 20 mics per kilogram per minute. But the 5 to 10 range right here, you pretty much only got beta innervation. Okay, so you did get an effect on increased heart rate, which is going to, by definition, increase cardiac output. You did get an inotropic effect, and so you got a better strength of contraction. But in order to get to the alpha receptors, you had to get to 10 to 20. And the problem that created is dopamine was very arrhythmogenic. So there was a study about a drug called activated protein C. That has nothing to do with, don't even worry about what that is. But in that study, it was a sepsis trial, they used the lower tidal volume, so the amount of air that a patient gets. They did 12 mils per kilogram versus 6, okay? And then they had a group in each of the 6 and 12 that got dopamine or they got norepinephrine. Now, norepinephrine, the brand name is Levophed. We used to refer to it as leave them dead. It's like if you went on norepinephrine, you've run out of options. And then we did the same for those who had a tidal volume of 12 mils. Now, remember, a tidal volume is just the amount of oxygen we're delivering to the patient. And this was probably the late 90s, early 2000s when this study came out. But what they found is patients who were ventilated at 6 mils versus 12 and had norepinephrine versus dopamine had lower mortality. So this became the drug of choice. And then they found 6 was better than 12 from tidal volume perspective, but within the group that were had a tidal volume of 12, again, lower mortality with the norepinephrine group. That's when norepinephrine became the drug of choice. Now, what was the why behind that? The dopamine was more arrhythmogenic. You had more cardiac arrhythmias and death in the dopamine group because you had to give higher doses to get the suppressor effect you needed. So they were having tachyarrhythmias. And because dopamine, you had to, in essence, innervate all the betas before you even got to the dose range that would start constricting in the periphery or the alpha receptor. So that's why you'll rarely see dopamine used in your practice. And that's why. I don't know if that's something we really needed to discuss in pharmacology, but to bring it to your attention because I want you to be able to understand why. So we talk about the beta receptors, rank order of potency again, isoproterenol, epinephrine, norepinephrine. Norepinephrine is our go-to now when we need pressor support for the most part. If you are having massive tachyarrhythmias and your left ventricular's intact, your left ventricle's intact, it's not disease, and there's not an issue with that at that point in time in the sequela, you can use phenylephrine, and that's pure alpha if you're having issues with tachyarrhythmias, because norepinephrine is not void of it. It's just not as likely. But we talked about the major subgroups, your beta 2, beta 1, beta 2, beta 3. And then, of course, beta 1 receptors, right, have approximate equal affinities for epinephrine and norepinephrine. Your beta 1 receptors are going to be on your heart. And then your beta 2 receptors, they have a higher affinity for epinephrine than norepinephrine. Norepinephrine does not get into, we actually have a product, an inhaler you can get over the counter. It was removed for a while, but it's back, called Primatene Mist, that asthmatics will sometimes have on them that they will take, but you have a lot of systemic effects with that as well. But in essence, it's an inhaler, where a meter dose inhaler, where you give yourself a couple of puffs of epinephrine to open up your lungs. Norepinephrine would not do that. So with norepinephrine, you're getting the effects on the heart, increase the heart rate, chronotropy, increase the strength of the contraction, an inotropic effect, but you're also getting the agonistic effect on alpha receptors, alpha 1, and getting that vasoconstriction, or that increase in blood pressure, increase in systemic vascular resistance that you're looking for. So the alpha 1 receptors, again, vasoconstriction, right? And you can read through these in detail. Beta 1, pretty much cardiac stimulation. You can read through. This slide's very important. You need to know this, even though I'm going through it somewhat quickly. You need to know it. Where are your beta 2 receptors? Again, vasodilatory effects, then beta 3. Again, we can use the beta 3 receptor in the genital urinary system of the detrusor muscle as an agonist, and it can actually increase your blood pressure some too. That'd be one of the side effects you'd look for in a patient who was doing that, but that would be more overactive bladder. We'll get to that. We're going to talk about that soon. So drugs that activate the sympathetic autonomic nervous system, so adrenergic agonist, again, or some pathomimetics, they have 3 classifications. Okay, they can be direct acting, indirect acting, or mixed acting. So the indirect acting agents, they can be releasers, they can be reuptake inhibitors, they can be enzyme inhibitors. And the enzyme for so the sympathetic nervous system, norepinephrine, those type drugs, serotonin, dopamine, what is it? Monoamine oxidase. So that's what we would inhibit. And we're talking about adrenergics, but a lot of this, again, ties into serotonin reuptake inhibitors, etc., that we use in depression. So your direct acting agonist, these are going to act directly on your alpha and your beta receptors. So they're going to bind to the adrenergic receptors on that end organ, that effector organ. Let's say it's the lung, without interacting with the presynaptic neuron. So you give Primatene Mist, right? You inhale it. You're going to get dilation. You give norepinephrine for blood pressure. We give isoproterenol to increase the heart rate because they're having some type of sustained bradyarrhythmia. Your dopamine, your phenylephrine, these are going to work directly. These are binding to those adrenergic receptors to get a response. And norepinephrine is going to be the ones, but they're mimicking. These other ones are mimics, but this is going to be the one we actually given it through an IV. Your indirect acting agents, these are going to block the reuptake of norepinephrine. So you're going to have more. You're going to have more norepinephrine available at the effector. Remember that postganglionic neuron and that effector organ. So you're going to have more available to give a pharmacological effect. So you're either going to cause the release of more norepinephrine and or inhibit the reuptake, or inhibit the degradation of epinephrine and norepinephrine. And remember, when we talk about degradation, we're going to be inhibiting monoamine oxidase. When we talked about the cholinergic system, the parasympathetic, that enzyme that broke down acetylcholine, remember, was acetylcholinesterase. Well, this is going to be monoamine oxidase. So, but potentiate the effects of epinephrine, norepinephrine produced endogenously, but do not directly. What drugs would do that? Cocaine and amphetamine are 2 of them. Now, I'm going to tell you, this is going to be more toxicology, especially with amphetamine. I want to give you a little warning with amphetamine. I see it. I work in the ED quite often, and you see patients come in who have overdosed on amphetamine. They're having chest pain. And it's real easy just to go into a watch and wait because it's going to wear off and it's going to go away. So they come in right here with chest pain and they tell you they were smoking or inject. Usually it's injecting. And then it starts to wax and wane and they go back to baseline. And this is going to be due to the vasospasms. Okay. So amphetamine and cocaine both, they will cause vasospasms of their coronary artery beds. And when you have vasospasms, you can have disruption of coronary blood flow, and you can get what I like to call a demand ischemia. But that's probably not the thing because you're not exceeding the demand, you just cause vasospasms. Well, the vasospasms, so you have it's not an infarct to say, but when you see that, it behooves you. The reason I put that in there is I would get an EKG more than once. When they get there, you're going to get one, and you may see some changes, but get another one, especially if it doesn't resolve, and here's why. And we see this with amphetamine, and I've seen this before. With amphetamine, for some reason, I don't know the why for this, but for some reason, you get that vasospastic angina. But for some reason, it causes disruption. If they do have coronary artery disease, which they very likely could, remember, you should think of amphetamine, we see people in their 70s and 80s that are abusing this. So that's going to come with maybe an increased risk of it. But the ones I worry about are younger people, and young people can have coronary artery disease. But it can cause disruption or destabilization of plaque membranes. And when you get disruption or destabilization, that's when you can have your STEMIs, your non-STEMIs, but many times your STEMIs. And just please be aware of that. You're going to get kind of numb to it because you're going to see it so much. They're going to be better. They're going to be better. We just need to watch them. But keep an extra close eye on them. Even if they're young, just make sure that EKG, if there is an anomaly, it's okay to double check it. It's okay to get troponins if you feel the need, but you're going to see this if you work in the ED, and it's going to be cocaine, but I see it more with amphetamines, probably because we don't see as much cocaine. It's a little bit more expensive. We do see crack, but it seems like from a stimulant perspective, amphetamine tends to be the predominant drug of abuse that I see, at least in Wichita Falls. Not saying cocaine or crack cocaine is not out there, because it certainly is, along with the depressant type drugs, fentanyl and heroin and those type of products. Okay. So epinephrine, we talked about it. You're going to get both alpha and beta stimulation. So remember, when you stimulate beta receptors on the heart, you increase the heart rate and you increase the strength of contraction. So you get a chronotropic and an inotropic effect. The low dose, you're going to get more beta. The high dose, you're going to get more alpha. So that helps you understand what are you going for. If you just need a little kick in the myocardium, but you don't need constriction, you're going to use a lower dose. And this is where understanding the pharmacology and the dosing and the physiology of how these work is good. So the actions and cardiovascular, this is going to be your go-to for your ACLS protocol. And shock, whether it's distributive or cardiogenic. So remember, it's going to be 1 milligram initially, and then every 3 minutes. Some will do every 2, but the protocol is every 3. So every time you cycle through, you give a dose, and there is no cap. It's 1 milligram. So, but that's going to be an ACLS protocol. That's where you're going to see it. You're also going to see it as a continuous infusion, right? To maintain, are you wanting to get some alpha constriction, or are you wanting more of a beta phenomenon with it, just to increase the strength of the contraction? Because you think it might be more cardiogenic in nature versus distributive or hypotensive. So you want to mainly make the heart a little bit stronger. And that's where the detriment comes in congestive heart failure, because your body will release norepinephrine when it's not perfusing. And it could be because you have a congested chamber in the heart, and that's not good. But yeah, it's going to strengthen the contractility of the myocardium. And again, that's a positive inotropic effect, and it's specific to beta-1 action. It's going to increase the rate of contraction. And again, that's a positive chronotrope, and that's beta-1 too. Also, increase renin release. And you can see if a patient is having decompensated heart failure, you can see how the body's trying to help you, but it can actually hurt you in many cases, especially with this renin release and the increased production of angiotensin II. Again, this is going to be sodium and water retention which is going to expand your plasma volume, and that's going to increase your preload, and it's going to give you more to pump against, so indirectly your afterload as well. And then respiratory, through beta-2 receptors, we get bronchodilation, okay? We use drugs like albuterol. We got several out there now that we use. Formoterol. We have those long-acting formoterol. There's a bunch of them we use that bind to the beta-2 receptors in the lung. We use them in the form of inhalers. And then the last for epinephrine, you know, the EpiPen in anaphylaxis, we give 0.3 milligrams. Now, anaphylaxis is interesting. Someone comes into the ED and they've eaten some peanuts. They had a reaction, anaphylaxis. So here they come. They're fine. They eat the peanuts and they're up here in anaphylaxis. Boom. They get hit with their EpiPen and they come back in here in their baseline. It is biphasic. So how long do you watch them? I don't know. Sometimes they will have another reaction in 4 to 6 hours. So I don't, some will say that it's not it doesn't occur enough to really have to make an intervention or keep them in the ED to monitor them for 4 to 6 hours. But I get so worried about it in case it recurs. Now, if they have an EpiPen or mom and dad or if they're adults, they understand what to do. I get it. But it can be biphasic. So just know when you're talking about an EpiPen, as it relates to an antidote to an anaphylactic reaction due to bee sting or whatever it may be, peanut, shrimp. So this goes on and on. Just know that can be biphasic, so it can come back. It can occur again, and you can get angioedema. Remember, we talk about anaphylaxis. People think it's this rash or skin. No, it has. It's if 2 or more organ systems are affected by the response, that is anaphylaxis. And one of the big ones that don't oversee it or overthink it is nausea, vomiting, diarrhea. It's the gastrointestinal tract, in addition to maybe the lungs and some constriction, and then the vasculature as well, specifically more of angioedema, that water leaching into tissues. And a lot of times it manifests itself as puffy lips, but a swelling of the airway, that's just how you see it sometimes. But think about your edematous airway doing that. And you hear, oh, it's my airway's blocking off, so not good. Okay, so therapeutically speaking, in terms of epi, we can give it IV, sub-Q, IM. We can nebulize it. We really don't do that. We talked about the cardiac arrest. We do it because it increases myocardial oxygen consumption. We talked about the bronchospasms, excellent for emergency treatment of bronchoconstrictions. We will nebulize it in young kids. I shouldn't say, but if you have stridor or near drowning, it actually becomes a pretty nice drug to use. Drug of choice for anaphylactic shock, right, and can be life savings in that setting through using what we call an EpiPen, and then of course local anesthesia. We will give it with like bupivacaine in anesthetic, because most of your local anesthetics, all of them except cocaine, will dilate. And so you don't get, so if you give epinephrine with it, you constrict the vasculature. So your anesthetic agent, such as your bupivacaine, doesn't leave the area you want to suture. Makes it hang around longer, so you're numb longer, and then you don't have as much bleeding as well. When we talk local anesthetics and anesthetics in general at a later date, though, cocaine is the only one that constricts. The rest of them actually cause dilation. So pharmacokinetics, fast on, fast off. What else is there to say? What metabolizes it? We'll talk about COMT at another time, talk some about the transferases, but monoamine oxidase, that's your big one. So if you give a drug that inhibits it, you can probably have too much stimulation from epinephrine. Adverse effects, just think of stimulation. Think of fight or flight. What do you get? You get anxious. You have fear. You have tension. You have headaches. You have tremors. That's why I'm a big fan of giving propranolol for like stage fright or anxiety, which is a non-selective beta-1 and beta-2 blocker, right? Propranolol. I take it myself sometimes. Cardiac arrhythmias, that can happen more likely with dopamine. If you're taking digoxin with it, it can increase the risk. You can have some pulmonary edema if you have a diseased left ventricle. That's because you're increasing your afterload, and you can't, and think about putting your thumb while you turn the water hose on high and you put more and more pressure over the end of the water hose. You're increasing what? You're increasing the afterload, what the water hose has to push against. And if you get where you can't push against anything, well, you're going to start having backup of water. And that's going to increase your preload, which is going to do what? That's going to go from the left ventricle back up to the left atrium, back up into the lung and pulmonary edema. That's how that happens. Hypothyroidism, you're already stimulated. You can get an enhanced response, the tachycardia, again, the hyperglycemia, and then you can get non-selective beta blockers to prevent the vasodilatory effects, etc. We talked about that. So you got to be real careful though when you're using some of these, when especially like if they come in with a cocaine overdose, giving these when your endogenous norepinephrine, epinephrine is being released, you want to make sure that you're careful not to give a pure beta blocker. You can give like a Betalol, which is alpha and beta blockade, but you want to be really careful not to do that, to give a pure beta blocker, because you can have unopposed alpha stimulation and it can lead to profound hypertensive urgency, emergency, and a stroke. It would be in the form of a hemorrhagic stroke in this case, not an ischemic stroke. So that's just something to keep in mind. We'll discuss that more later. Norepinephrine, again, it's working similar, but it has to do with the affinity of alpha and beta. But you're stimulating alpha. You do stimulate beta, but less so than epinephrine, really, in my opinion. And for sure, dopamine, you're getting more of an alpha effect, but you are having beta effects. But again, we predominantly use it in distributive shock and to create vasoconstriction to increase that peripheral resistance. And that way, if you don't have success with volume resuscitation in that distributive shock, volume resuscitation is the key word, then we got to try to clamp them down with the vasoconstrictor. So this is what we do, and these are the effects we get. So not as much activity on beta 2. You're not going to use it for asthma for sure. The baroreceptor reflex, this is increased vagal activity, so you can get a reflex bradycardia. Atropine would be the vagolytic to do that, to give stimulation of the heart by norepinephrine, but I've never seen this. I have never, and I've seen a lot of norepinephrine use. I've never seen a baroreceptor reflex where I get increased vagal activity and have a reflex bradycardia. And that can be profound in a patient that needs more cardiac output. But I guess, I don't even know why I have it in there. I probably read it somewhere. It would be good to say, okay, what if someone had sinus bradycardia and you needed to give something atropine, right, for its vagolytic activity? Therapeutically speaking, the primary use is going to be in distributive shock initially, and that Zygris study that we talked about, the Prowness study, that's what told us. It has a very short fast on, fast off, so it's always IV infusion. We don't really give norepi sticks. We'll give phenylephrine sticks. You'll see phenylephrine give IV push every now and again, especially anesthesiologists. But it's rapidly metabolized again. The big one is monoamine oxidase. And the adverse effects are going to be similar to epinephrine. And then we try to avoid peripheral administration if possible, because if you do get extravasation, it can cause profound vasoconstriction and tissue necrosis. So we try to avoid peripheral administration. But now, if all you have is a peripheral site, don't let that be a reason not to get it, but try to get it. But you can give it, one thing I didn't mention a lot, you can give these drugs intraosseous too, through the bone. So if someone comes in through EMS in the emergency room, and the kids or adult, and as long as it was placed correct in that correct position, you can give it that way as well. But if someone tells you you cannot give norepinephrine through a peripheral line, that is not true. You can. It's fine. The only reason we try to avoid it if we can is because if you do have extravasation, it can be detrimental. So that's the only reason why. So keep that in mind. Dopamine, we talked about the why we don't use dopamine, but this is a precursor to norepinephrine. It occurs naturally in the CNS and the basal ganglia, where it does function as a neurotransmitter as well as the adrenal medulla. So it activates alpha and beta. Now remember, in order to get to the alpha-1 receptors to get vasoconstriction in that distributive shock, you have to give higher doses. And what are those doses? It's going to be more than 10 micrograms per kilogram per minute. Don't bark, Cooper. It's okay, Cooper. Cooper, no. It's okay. So my golden retriever, the UPS man just dropped something out. My golden retriever lectures with me. The low doses, though, stimulate beta first. So you notice when we used it in the context of the Prowness study, we were given to give higher doses. So in essence, you just bombarded the beta-1 receptors before you could appreciate the effect on alpha. to constrict it, right, with alpha receptors, binding to alpha receptors, causing vasoconstriction. And subsequently, the problem is you had all this activity at the beta receptors. It was more arrhythmogenic, so keep that in mind. It does activate the D1 and D2 dopaminergic receptors, which you see in peripheral mesentery, but also renal vascular beds. You can get a vasodilatory effect, but again, I've said this in previous lectures, it's a medical myth of renal dose dopamine, which is defined specifically as 2.5 micrograms per kilogram per minute. It's not effective. Doesn't work. It's a myth. Doesn't work. So actions, again, the cardiovascular, those B1 receptors of the heart, we get that positive inotropic and chronotropic effect. So we're getting the increased strength of contraction, and we're also increasing the amount of blood because we pump every minute because we're increasing our heart rate. And then the alpha-1 receptors of the vasculature, the higher doses are required, we get that vasoconstriction. So we're getting an increase in cardiac output due to strength and increased pulse, but we're also getting an increase in peripheral vascular resistance due to clamping down. And there's the renal and visceral. It dilates renal and splanchnic arterioles. This is it activates dopaminergic receptors, increasing blood flow to the kidneys. Okay, so that's thought that low dose or renal dose dopamine would be effective in preventing kidney injury, but that has not been shown to be effective in prevention or the treatment. Does not decrease urinary output. There is a drug called Polipam that does, but therapeutically speaking, we can use it for cardiogenic and septic shock, which is distributive. The cardiogenic, because you are getting the activation of beta receptors. We need a heart just not working. You want to be careful of increasing in cardiogenic shock. You want to be very careful not to increase your afterload too much, because that diseased heart, it's cardiogenic in nature, might not be able to pump against that. So keep that in mind. So, and the rest of this, again, we talked about. So phenylephrine, this is going to be specifically alpha-1 receptors. So if you're an agonist at the alpha-1 receptors, you're innervating them, you're going to cause constriction. So it's a pure vasoconstriction. And it raises systolic and diastolic blood pressures, but has no effect on the heart itself. Now, sometimes you can get a reflex bradycardia, but it doesn't have an effect in and of itself. You also see phenylephrine used in your OTC decongestants, both as a spray and as a tablet. Remember, you have to get pseudoephedrine behind the counter. It's not a prescription, but behind the counter. A lot of your agents will have phenylephrine, and it doesn't, which actually I think it's being removed from the market because studies show it's not effective at decreasing congestion. Sudafed's pretty much all that works for me. I think this, though, makes me feel weird, and when I use it in that mode for congestion, it makes me feel weird and it leaves a bad taste in my mouth, but it has no effect on the heart itself. So you'll see it in the critical care unit. We use it for hypotension. It's a very good choice in patients who are tachycardic and you don't want to give something that's going to have more stimulation, but just please appreciate if it's cardiogenic, just pretend like this is the left ventricle and it's just barely, that's what it's producing when it should be producing this. If you give an alpha agonist and you constrict, you may substantially decrease what this diseased ventricle can pump against, and it's going to cause an increase in preload because it can't eject all the fluid, and that can back up and cause a lot of issues. But, fact check me, guys, but I thought the FDA sent out something that said phenylephrine in decongestants was going to be removed. And I liked it because you could get it in front of the counter. It wasn't behind the counter. You didn't have to ask for it. But why is Sudafed behind the counter? Boom, precursor to methamphetamine. So we all get punished. Oxymetazoline, nasal spray, alpha-1 and an alpha-2 adrenergic receptors, OTC nasal spray congestant. We usually limit for 3 days total because you can get rebound congestion, and that can lead to dependence. It also is used as an OTC ophthalmic drops for relief of redness of your eyes. So I don't recommend it for that. Most ophthalmologists don't like it for that, but it gets the red out, right? Vasoconstriction of blood vessels supplying the nasal mucosa, right? Decrease nasal mucus or snot, so decongestant, and the same thing in the conjunctiva, decreasing vascular congestion or it gets the red out, those red eyes. But adverse reactions, you can, if you get systemic absorption, nervousness, headache, trouble sleeping, and an increase in blood pressure can occur. Isoproterenol, rarely used, very expensive. It's a synthetic catecholamine, which stimulates beta 1 and beta 2 adrenergic receptors. Very insignificant alpha innervation. So this is something that we're going to use to increase heart rate for contractility or cardiac output. We rarely use this. We have so many better options now. The beta 2 effects, again, you know what that does. You're going to get arteriolar dilation. Skeletal muscle, you can get bronchodilation. We never use it for that, though. Potentially get a decrease in peripheral resistance, and you can go through these. We rarely use them. But when you want to talk about adverse effects, see epinephrine on that. It's pretty much the heart. Isoproterenol, at least in my world, you see it every now and again, but not often. It's usually going to be more stress to try to, you have someone in the cath lab or something like that. And we even have cheaper drugs to use, though, instead of isoprel. That's the brand name, is isoprel. But every now and again, you'll see it in the ICU as a continuous infusion, but it's typically not prolonged. And so, but you don't see it. Midodrine, this is a drug that during the scenes in the ICU, it was going to be pulled off the market. This is a selective alpha agonist and was used for more of orthostatic hypotension, okay? So it increases arterial and venous tone. So the uses was rarely utilized. Its indication was for treatment of orthostatic hypotension. You saw it a lot of times in patients on hemodialysis. Rarely utilized, but then they found that in the ICU, you could give higher doses. And if you're going to give it in ICU, so say someone, they're still having issues with their blood pressure, and they still have to stay on norepinephrine. I like to call it a sniff, but you can't get it off of it. So they just need a small little sniff of norepinephrine. A low dose is going on IV. You can't get them out of the ICU until you get them off the pressor. Many times midodrine, well, I shouldn't say that. I haven't looked at all the studies. Studies show that midodrine may be a benefit, but don't give little 2.55 milligram doses. At minimum, start at 10 milligrams. Okay. And at least BID, I do it TID. You may need up to 20, but don't start low or you're not going to get a benefit. If you're taking it at home, once they're off the presser, you can stop the midodrine. If someone is taking it chronically, you do want to make sure they take it at least 4 hours before bedtime. This is very important, okay? It could be a test question. And when you lay down flat, remember supine, right? Laying down flat. I guess prone too, laying on your head, but you're laying down flat. Doses within 1 hour of bedtime are not recommended. That's because you can actually have some hypertension. Your blood pressure can go high at night when you're sleeping, and that's the silent killer over time. And then if it goes too high, from a more acute perspective, it can lead to potential hemorrhagic strokes. But again, in practice, this is the ICU patients on pressure support. So again, requires a higher doses. But if you're going to do it, when some of you will go work in those settings as intensivists, make sure that you start at least 10 milligrams. But midodrine, in terms of a outpatient type situation, rarely utilized. FDA was going to pull it from the market, but then they found this potential use in the ICU, so it stays. Phonodipam, this is a drug, brand name is Corlapam. It works specifically on D1 receptors. Now, I told you renal dose dopamine didn't have an effect in terms of preserving kidney function or preventing progression of kidney failure, and it didn't increase urine output. Well, phonodipam, it's used for blood pressure, but it's a rapid-acting vasodilator to treat severe hypertension in hospitalized patients. It never really caught on. It was expensive. I've only seen it used a few times, but we give it to an IV infusion. I haven't seen it used in years, but I will tell you, it will lower the blood pressure, but in the kidneys, this will actually increase urine output. It's one that, now, maybe not anything for the kidneys, but if you're just looking to treat a number, the urine output decreased, you'll get it. Dobutamine, don't confuse this with dopamine. It is pretty much specific to beta 1 receptors. This actually lowers the blood pressure. It has minimal beta 2 or alpha 1 effects. So, but we use dopamine in those cardiogenic. So a patient has return of spontaneous circulation or whatever, he's got to have a code blue, and it's not more, you think it's a cardiogenic shock, this would be a drug to go to. Their blood pressure is low. You automatically think norepinephrine. Well, if it's a diseased heart, maybe dobutamine is what you need. It's not the vascular that's the problem. It's the heart not working. So when you give it, again, you're going to get that positive chronotropic effect. The dose is the same as dopamine. It's 5 to 20 micrograms. You're also going to get that increase in cardiac output through the strength of contraction, the inotropic effect. But a few vascular effects, but you can see a little dip in hypotension, but you hope by the chronotropic and the inotropic effect, that in and of itself increases your blood pressure. So you need to make sure you appreciate that when you choose to use dobutamine. You don't always need a pressor agent. Sometimes you got to look at the root cause of your problem, and you can't just throw a sink at everybody. They might not need a sink. If it's not a distributive shock that's the problem, volume resuscitation and cardiogenic shock could be a detriment. Giving something that's an alpha agonist as well could be a detriment because you're trying to treat a number, blood pressure alone, without appreciating what is actually causing the decrease in blood pressures. And you know your main shocks. A lot of you're going to see distributive. You see that in the septic patient due to an infection. That's a dysregulated immune response due to an infection with resultant end organ damage. A lot of times it's the kidney, but it's any organ. It can be. So keep that in mind. But you have your hemorrhagic shock and, you know, massive transfusion protocols. We need volume there, right? And then, of course, cardiogenic shock. So keep that in mind. Your alpha-2 receptors. So these are located in the CNS. I'm going to go ahead and turn my timer off because we are going to get through the rest of this, I think. Your alpha-2 receptors located in the CNS. These function as autoreceptors. And when activated, they inhibit adrenergic signaling, reducing sympathetic outflow. So when I give a drug like clonidine orally, 0.1 milligrams in the ED, or a patch, a clonidine patch, you can initially, if you were to give clonidine IV, you would actually get alpha-1 agonistic activity initially and get a little spike in blood pressure. That's why we don't do that. Until it saturated the CNS and you blocked alpha-2 receptor, well, not blocked them, you agonized them. So don't let that fool you. Alpha-1 receptor agonism increases blood pressure. In the CNS, those alpha-2 receptors, when we agonize those, we actually decrease sympathetic outflow. And these are your drugs. Your big one is clonidine. Your bromidine, the alpha-gam, that's going to be used more in the setting of glaucoma. It's an eye drop. Guanabins, that's another one. Guanfacin, Tenex, methyl-dopa. These are the ones. Xanaflex is one we use for very various reasons, for more muscle relaxation. But you can see there, this would be the tizanidine, the Xanaflex. That's going to be muscle spasticity associated with cerebral and spinal disorders. But yes, we actually use these for hypertension and then glaucoma, the bromidine. Methyl-dopa used to be the drug of choice in pregnancy, but we have some better options there. Methyl-dopa has some associations with lupus and other things that go on with it. So many more acting adrenergic agonists used in urology and pulmonary medicines. Again, these will be discussed in future lectures. Okay, so indirect acting adrenergic agonists. So these potentiate the effects. Epinephrine and norepinephrine are doing the work that's produced endogenously, right? But something indirectly is increasing the amount that is available. So we're not having a true effect on the postsynaptic receptors. We're just doing something to make what the body already makes to have more. And we can do that by increasing the release and or inhibiting the reuptake or inhibit the degradation of it. And what do we see? In these cases, we can get hypertensive urgency and emergency with end organ damage. So when I see this, you know, I'm channeling cocaine and amphetamines come to mind initially, but enhances release, mixed acting. These are going to enhance the release of stored norepinephrine from nerve endings and directly stimulate both alpha and beta receptors. Now, ephedrine, we don't see this. Used to be able to get this back in the day over the counter. You'd have people who needed to study and stay awake. They were called mini thins, and they were found in a lot of diet products. I've actually taken them before instead of coffee. I'm not a coffee drinker, but I'd like to take one or two when I needed to stay alert to study. Those have been removed from the market as well. The reason being is, what's it a precursor to? Like pseudoephedrine, amphetamine. So, but these here, especially the very high doses, we were seeing a lot of coronary artery vascular type issues, a lot of major adverse cardiac events with patients because of it. But the mini thins is what it was sold under. Truck stops, truck drivers, but it is a banned now, and that's a good thing. My experience with it, I take one or two, and you could get them at the store instead of coffee, and it's just like drinking a bunch of coffee to stay awake. You're still super tired. Now you just can't sleep. And so I never found them to be benefit. So, but I never put myself in a situation to cram for tests. So that's a good thing. And then, of course, those that are also mixed acting, meaning they're going to increase the amount of norepinephrine and also act upon those receptors as well. Sudafed is that. So I believe your new textbook, the table is 6.16 for specific drugs. These are ones, though, we will discuss in more detail later. So our focus, when we talk about antagonists now, adrenergic blockers, these are going to be your beta blockers and your alpha blockers. And we're talking blood pressure, we're talking heart rate, we're talking CHF, and we're talking neurological procedures. That's where we're at right now. So I want to back out right quick. I want to see. So I think we're going to stop. I don't want to go too fast because there's some good stuff. So this is week 4, lecture 1, and stopping right here, this is going to be where we stop for your exam. So let me stop the share and pull up the form. I want to discuss this right quick. So, and we're doing good on time in terms of where we need to be and where we're going. So I'm going to share this. So I don't want to rush through that.
You started screen share.
Why does it do that? Can y'all hear that? The thing talks to me now. If any of you know how to turn that off, please let me know. So, but is this what I'm sharing? Let me try again. Boom. Boom. Okay, that's where it is. So
you have started screen share. Your screen sharing is paused. You are screen sharing.
Okay, so here's where we're at. So on the 2nd at 1 p.m., that's going to be your exam. So we're going to, on week 5, we're going to pick up ANS, and we're going to do beta block. And it won't take long to get through them, but you can see here we'll have plenty of time, none of your tests. When we get to the end, there's not a lot going on with respiratory. Your final will be comprehensive, but you'll have 50 questions and then maybe 15, but a lot of this will tie into it, a lot of the cardiology stuff, so it's not going to be a problem. So the autonomic nervous system, we'll finish up. We're going to go into, this gets us week 4, lecture 1, and then we'll start with week 5, lecture 1, and we're going to finish the autonomic nervous system. We're going to go into beta blockers. So that'll put us done with that. And then we'll go into the genital urinary. Now, remember what I said, though, a lot of this is going to make easy. We'll fly through genital urinary because a lot of the stuff we do is what we've already discussed. We just need to put it in the proper perspective. So anyway, that ends. Your exam will be everything we have discussed up to this point. It'll be on February 2nd, 2024. And in your testing room, you'll have a proctor there. But everything we've gone through the autonomic nervous system, but I need you to stop when you get to this slide. Let's go ahead and just do another share real quick. I want to make sure I pull up the right one. Zoom, share. Right there. Okay, right here.
You have started screen share.
So when we get to this part here, so it's going to be slide 97. So in essence, all we have to do is go through our alpha blockers and our beta blockers. We could get through this quick, but I don't want to because this is very important. This is high yield and a lot of good information. So, okay, that gets us up to exam 1. And we're going to, again, slide 96 is where we cut off. Okay, we're done. And we're going to pick up on week 5, lecture 1. This is week 4, lecture 1, and it's the only lecture for week 4 because you have your first major exam coming up. So anyway, we will stop the share, and yeah, let me know if you have questions. Thank you.